So when someone in our community hears the word cancer for the first time, what do you want them to understand that they probably don't?
So, take a deep breath.
Okay.
Oftentimes we have to complete the staging, so the stage dictates the treatment. Cancers that are caught earlier often have less treatment recommendations, which means less toxicity, and also caught earlier means better outcomes. So hopefully we caught it early.
Yeah.
And even if it's an intermediate or a slightly advanced stage, we still have great treatments. Like I was saying, all the immune therapy and targeted therapy now that people are living longer with good quality of life. So there's still really great outcomes. And then I tell patients, if it is a more aggressive cancer or poor outcomes, I always have that conversation with the patient. One, how much do you want to know? Because some people actually just don't want to know.
Welcome to the CCCNews Podcast. I'm Tom Peterson, and today we have the pleasure of speaking with Dr. Winifred Wong. She is the radiation oncologist and medical director at the Celilo Center at the hospital in the Dalles. It is part of the Adventist Health Columbia Gorge system, and Dr. Wong brings more than a decade of experience in cancer care with a background that includes service as a physician and a leader in the U.S. Air Force before coming to the Columbia Gorge. She specializes in radiation oncology, working with patients through some of the most difficult moments of their lives, helping guide treatment with both precision and compassion. Thanks for coming, Dr. Wong.
Thanks so much. Feel free to call me Winnie, since you're my neighbor.
Very good. Yeah, that brings up a good point. We've met each other over the last several years on different occasions, shoveling snow together in your driveway.
Absolutely.
Yeah. And, through that, we had some great conversations, and we were chatting a little bit with me about like kind of growing up and how your parents were kind of in the restaurant business, and you kind of moved quite a bit as a youth.
Yeah. So my father was in the corporate side of the restaurant business, so we moved every 3 to 4 years. The longest I've ever lived anywhere was in the Seattle area for 7 years as a kid.
Yeah.
Usually every 3 to 4 years. So lived in Seattle, Dallas, the Boston area, and then I went to college on an ROTC scholarship, and I think that was so ingrained in me to move that that I moved every couple of years with the military,
right,
as well.
Yeah, and that was comfortable for you.
Yeah.
I mean, kind of, is that kind of growing up in that crucible, if you will, having to change schools and meeting different people quite a bit, like that's probably made quite an impression on you or kind of shaped you in some ways?
Yeah, I mean, it makes you be flexible, and it makes you really, as a military officer during my training once told me that your best assignment is your current assignment, which is essentially to say you just have to make the best of every situation.
Yeah.
And so my mom was really good with that too. Always got us involved in sports right away, activities, got a map of the area, and we went around and did activities. And so, try to get us involved in that local community as quickly as possible.
Yeah.
So it really did give you the ability to just be kind of flexible and adjust to any setting.
Huh, awesome. You told me a funny story. I think was it about being in Alaska at one point?
Yeah, so after college, my first assignment with the military was up in Fairbanks, Alaska as a logistics officer. And so I was there for a little over 2 years prior to going into medical training and becoming a physician. But yes, I was up there for 2.5 years, right out of college, 21. I'd only lived in cities, and now I'm in very dark, remote Alaska where it gets to negative 60. It's,
right. Oh my
dark,
gosh.
Most of the winter. And so that was a learning experience as well.
Awesome. Well, we're lucky to have you in the Dalles, to have an oncologist and a director for the Celilo Center. I think you've really brought in some nice, stable staffing and that kind of thing. We kind of were off and on for a little bit there while things were kind of getting figured out. And so thank you so much for giving back to our community in the ways that you have and helping so many. Yeah.
Yeah. And thanks to the community for, welcoming me. I've really enjoyed everybody's been so nice as far as neighbors, patients, staff. It really is a tight-knit community.
Yeah, it's so funny. Like we were kind of chatting, and like when you meet somebody, you'll almost always run into a story of like how they know somebody else, and it may be through 3 or 4 other people. But That's kind of the joy of the dolls.
It is, absolutely. And it was funny coming from larger cities. You'd be at the grocery store and someone would just be talking to you across the oranges, like, how are you doing? And I look around, I'm like, oh, you actually want to know how I'm doing? Just a random conversation at the grocery store. I'm like, okay, like people are really engaged here, which is nice.
Yeah, that's the joy of it. Another fun little thing that between us, we were, Peggy and I were out walking one day and you had a bunch of painted rocks.
Oh, yeah. So a patient, as a thank you, brought in all these really pretty painted rocks, like ladybugs, bumblebees, pickles, like dill pickle rocks. And they brought in so many that, the staff, we all grabbed some. And so I came home and asked if you wanted some because you do all the gardening. And then actually the next door neighbor has a little 2-year-old son. And so I gave him some. But they're just fun to put in your garden in the neighborhood and around the area.
Yeah. So that leads me to ask, do you believe in the butterfly theory?
Yeah, I mean, every small action has its, terminal action. So 100%, it's, be nice to everybody. You never know what anybody's going through. And so, yeah, just have that nice effect that hopefully down the road it has bigger nice effects.
Yeah. And that's kind of that little ripple, like one kind thing kind of gets another. And
yes,
what is it? The butterfly flaps its wings, but that
it makes a hurricane in Florida,
Yeah, exactly.
Yes.
Yeah, that's so cool. Yeah. So the other really fun aspect about you, Winnie, if I don't say so myself, you share a lot of your life online and what you've made, and you've kind of decided to be a little bit open, like you show cooking, how you're cooking and some other things. But maybe that's a little bit different for most doctors. It seems to be in my experience.
Yeah. So on my personal Facebook that I have friends and neighbors with, I'm an avid cook and baker. I've historically always been a baker. It lends itself to kind of the science mind because baking is science. It has to be very precise, and each ingredient is actually like a scientific reaction versus cooking is much more kind of artistic, a pinch of this, pinch of that. And so I hadn't been much of a cook before COVID, and then COVID, gave you time to learn a bunch of new stuff.
Right.
so I really got into that, bought way too many cooking gadgets. My garage has a whole shelf now of COVID buys. But yeah, so I love to do the cooking, love to do that online, hoping to grow that a little bit now in the Gorge with all of the great, farmers, ranchers, farmers markets, and hoping to do a little bit more of that going forward in the future. But other things I share too, not only on, personal Facebook, but also, LinkedIn and Instagram and so on is, cancer screening, cancer outreach, so that's really important to, if you're going to talk the talk, you need to walk the walk. So I even did that this year where the whole prep, I had my first ever colonoscopy this year.
Okay.
And so did went online and had videos of the prep. When I was under sedation, I actually had the anesthesiologist take pictures of the colonoscopy, and, and so put that online just to let people know it's not that scary. It's not that difficult. It's, annoying for maybe about 24 to 48 hours, but it's a small price to pay for, knowing that you don't have cancer.
For longevity. Yeah. Absolutely. Yeah. I did that at 50 as well. And it's quite an experience. I will say, however, though, once I got to the hospital and was under sedation, nothing.
No. Yeah.
Woke up and oh, we're done.
Yeah, exactly. Yeah. Super quick, get up and, go home, take a nap.
Yeah. Very good. Yeah. And very important in catching, early starts of cancer. So
absolutely.
Yeah. Very good. Another question I have is tell me a little bit about your dogs.
Oh yeah. So I've always loved dogs. We always had dogs growing up. And then obviously through medical training, I couldn't, I just didn't have the time. The schedule didn't lend itself to it. And I had, an apartment and whatnot. So that was always my, life goal, Pinterest board or whatever. Once I finished my medical training, I was going to have dogs again. And so I did. I got my first dog as an adult right after residency. Actually adopted her. I literally drove out of Seattle. I picked her up on the last day of Seattle of residency. And I drove to Texas, and I adopted her from a nurse that I had worked with in Seattle. So it's kind of 6 degrees of separation. Where, they were getting, the nurse and his wife were getting older, and she was a very fit, active golden retriever. So they couldn't take care of her. And so we kind of co-parented her. I had physical possession, but always sent her videos, and they were sending us gifts. And so I've always had dogs. And so now I have 3 little dogs. So it's kind of morphed from one big dog. Now I have 3 little ones. So my neighborhood always sees me out there walking them. Two of them are older with arthritis. One of them's younger. So I actually go on 2 walks every night.
Was the last one a rescue dog? Or
they're all rescues.
They're all rescue dogs.
All of my dogs, even if they're purebred, they're always rescues. So I kind of believe in that. I like the rescues. And they've always got quirky personalities, and then they generally know that they've been rescued, so they're very loyal to you. And
there you go.
So they're always a fun group to have.
Yeah. Well, awesome. Maybe that leads into my first question a little bit too, and we kind of talk a little bit more about what you do and that kind of thing. But how do you unwind after a difficult day of work, treating folks? Because it's not always probably a positive or outcome or that kind of thing.
Yeah, no, there are definitely days that are harder than other. But yeah, go home. Throw on some shorts and flip-flops, get out of your work clothes and kind of decompress, take the dogs for a walk is always nice, some fresh air, not looking at a computer screen, not listening to a phone and things like that. And then, cooking is always a big stress relief. So I just kind of like the methodical, even the prep of, chopping up the vegetables, things like that. Just kind of very soothing just to get into a different rhythm.
Yeah. Has it changed your outlook on life because of the patients you've treated? Do you think it?
Oh yeah, no, absolutely. So my specialty is an oncologist, as well as like having served in the military as a logistics officer, which is a line job, so people deploy, and so I worked on deployments and supply chain and transportation convoys and things like that, and so people were definitely put in harm's way then. So I had subordinates that had to work with them on that. So you had life perspective from the military because people were deployed, people had issues. And then medically, obviously working with cancer, my goal is always to cure it or make you feel better. But sometimes, there are harder days where people are not doing as well or people pass away. And so trying to get through that, you do have to get home and decompress and kind of, you take it home to a degree, and then you then kind of compartmentalize a little bit just so you can get back at it the next day.
I think there's a thread of that for all caregivers.
Yes.
When you're working with folks that are kind of towards the end of their life and that kind of thing, and it's hard not to internalize all that.
Yeah.
But also there's kind of something special about that time in life too, of really being in the now and understanding that maybe these could be a few of my last days or what have you, and to embrace them and to fully feel them.
Yeah, absolutely. So it gives you that kind of that YOLO, you only live once, so if you have the time now, do it, while you're fit and healthy and have the capability. I
think you live your life that way.
Yes. I get out there, go hike, go, if I'm in an area, you got to go experience it. One of the best was I did my residency training at the University of Washington in Seattle, and I was doing a rotation at the Seattle VA. And there was a veteran patient, and he was coming in for just end-of-life palliative care, so helping him with symptoms. And he and his wife had been RVing across the country, and I was telling him, like, oh, gosh, that's always been on my list. But, the military moves, they give you a short time hack, so you need to be at your next base at this time, and if you extend, then you need to take either a vacation day or you get in trouble. And so I was like, gosh, I've driven across the country several times with the military, but I haven't really been able to see it because I've been on such a time crunch.
Right.
And I remember he just looked me straight in the eyes, this guy who's dying, and he's like, take the time, and so those things do sit with you.
Yeah, exactly. It's like enjoy the journey kind of thought, right?
Yeah.
Like, I'm just trying to get to, Chicago. Well, there's a lot between here and Chicago,
exactly.
Right?
Yeah. So I enjoy that even on so I even try to do that now on road trips, just
take back roads and stuff.
Yeah, take back roads, see the weird things. Like when I was stationed in Northern California, if I would drive up to Eugene, Oregon, where my parents were living at that time, you go past Corning, which is like the olive capital of California.
Yeah.
So there's a place called the Olive Pit, and everything is olive ice cream, canned olives. But there's all these olive groves, and they supposedly, who knows if anybody's actually tracked it, it's the world's largest cement olive in one of the olive groves. So I took the 1 mile detour up the highway. I was like, it's here. I got to see it. So I have a picture with my dog, the two dogs I had at the time, in front of this giant cement olive, just because it was there.
Awesome. Did you try the olive ice cream?
I didn't try the olive ice cream. I tried a bunch of their other olive stuff though that I did like. Yeah.
Apparently, there's such a thing as garlic ice cream as well.
Yeah. So south of Sacramento, about an hour or two south, there's a place that does a garlic festival. And so garlic ice cream, a lot of garlic stuff.
Have you had that?
I did not try that. I was just like, I'm good. Yeah.
Very good. Very good. So I'm going to jump into a little bit of the science questions,
absolutely.
if you can. So for someone who hasn't been following cancer research closely, what's changed the most in the last 5 to 10 years, would you say, Winnie?
So the biggest thing is colorectal cancer is actually occurring in much younger groups now. So historically, the recommendation for first colonoscopy was starting at age 50. A few years ago, it actually dropped to age 45, just because we're seeing it younger and younger. And there was actually a report that was put out this past December, January, that showed that actually all rates of cancer in the United States were decreasing over the past few years, except colorectal cancer in those under 50. So in colorectal cancer in those under 50 has actually been increasing. And they expect, I think, around by 2060 for it to be something like 3 times greater than what it has been. So they're not quite sure why. I think a lot of it's environmental. We do eat a lot of ultra processed foods, the microplastics in the environment, things like that. But they're still working on that. And so I actually fully anticipate in the next couple of years that they'll probably say first colonoscopy at age 40 or even younger.
Really?
Just because it's occurring so much younger. And then the problem is in younger people, it tends to be a little more atypical presentation. So historically, we'll say for colorectal cancer, if you have blood in your stool or the change of your stool caliber changes. But I've been having younger patients, 38, 40, that are just like, I had, constipation or just kind of abdominal pain, and they get brushed off, like, oh, you're a fit 30-year-old, what's going on? And so it actually delays their diagnosis, delays their time to treatment, because they are just presenting in an atypical way as well. And so it's something we need to look at there as far as colorectal cancer. It is occurring younger and younger, and why is that?
Yeah. So for the person out there right now who may be experiencing that, is it something that's persistent over a couple of weeks?
Yeah. So if it's persistent, as well as maybe other symptoms such as like unexplained weight loss. So I've had some patients that maybe they still look fit. Like I had one gentleman who had been a very fit kind of bodybuilder.
Yeah.
So even when he lost 40 pounds, he still looked fit because he had been so big.
Right.
But if you knew him, you'd be like, something's going on.
Yeah.
And so that got missed somewhere in being follow up. He was being persistent. He kept going to his primary care physician saying, like I have this abdominal, like I have this constipation and I'm losing weight. And I think that he got brushed off because he was a young guy, unfortunately.
Yeah.
So it took he probably had a 6-month delay until he actually got diagnosed correctly. So he's doing well now, but he had to go through a lot of treatment that maybe if we had caught it earlier, he could have done less treatment.
And as a young person too, you're not going to think that they think,
No, exactly.
So the thing that I've learned, it took me a long time, but you really have to advocate for yourself,
100%.
like a second, third opinion kind of thing. Like if it's still gnawing at you, you got to get out there and see if somebody else can't.
Yeah, absolutely. So get that workup. And so that's the main one is colorectal cancer in younger populations.
Okay.
And then we also have more targeted therapy. So most cancer patients now, when they come in, will often get a genetic testing done, their tumor will get profiled. And so we have a lot more targeted therapy. So it's not just standard chemotherapy that people think of nowadays. There's immune therapy that, bolsters your immune system to fight the cancer. And there's targeted therapy because certain cancers can have like receptors on them that certain medications can target and better treat them. And so, for example, like lung cancer. So stage 3 lung cancer, when I started my residency training at University of Washington in 2009, stage 3 lung cancer, even with best available care, surgery, chemo, and radiation, the median survival was 15 months.
Wow.
Now we have patients 6, 7, 8 years out because we have immune therapy that we add on. It's a medication called durvalumab, and other medications we can add on as well, but it's completely different. I mean, 15 months back in 2009, and here in 2026, people 6, 7 years out and doing well, good quality of life. It's not just, I always want to make sure that patients, yes, can we cure you, but what's your quality of life?
Right.
So they're cured and good quality of life.
Yeah. So my standard on that quality of life is if you can get up in the morning and still smile.
Yes.
And still have a sense of humor. Like humor is very important to knowing your quality of life, I think.
Yes.
And that's kind of my standard.
Yeah.
Like,
and just can you do your normal activity of living? Can you get up and get yourself to the bathroom? Can you brush your teeth and make yourself breakfast?
Yes.
Can you go downtown and get coffee with your buddies? Just it doesn't have to be huge things, but some basic quality of life. Yeah.
Right. Yeah. Yeah. Very good. So do you think cancer is moving into something that's more manageable, like chronic disease?
Some of it, yeah. So, for example, like the stage 3 lung cancer, a lot of that immune therapy, oftentimes people may be on that for life. Or sometimes we give them a break, but we continue to image them every, 3 to 6 months.
Yeah.
So it's kind of like, diabetes, where you still have to come in and get your blood sugar checked, and maybe we have to tweak your medication. So there is a lot of cancer that is going to be chronic management like that.
Wow.
But then there are some that you have mutations, so again, like colorectal cancer in young people, like what's going on with that? So it's kind of a balance there that, yes, we're getting better with some, and then some others are kind of evading us right now.
Maybe the older problems, or for lack of saying it in a better way, but the older problems, like the solutions are coming on those.
Yeah.
But of course, there's other things that are going to crop up in nature. That's just like you say,
evolution,
mutations, evolution, and that kind of thing. Is there an advancement in treatment technology, AI, that generally excites you right now?
So AI has been coming on the forefront a lot, actually, with medicine in general. So something as simple as, helping physicians in the medical record, helping them get their notes done quicker, which is really beneficial primarily to primary care physicians that see a high volume of turnaround. But in oncology, sometimes the AI can help you prep the note ahead of time, collecting all of the imaging reports, pathology reports, and getting that into kind of like a prepped note that you can then tweak afterwards. Coming up, actually, in September, our hospital, so currently the electronic medical record for our hospital, we actually license it from OHSU. So we're using OHSU's medical record. Coming up in September, we're actually going to switch over to the Adventist corporate one.
Okay.
And that one actually comes with an AI feature that you can actually, with patient's permission, of course, put an app on your phone. When you're in the room with the patient, it records the note. It can tell kind of the wheat from the chaff. So you're talking about your condition, but say we get to going on a tangent about talking about my dogs. It understands that your dogs have nothing to do with your lung cancer, and it'll take it out of the note. So it knows not to just record an entire conversation. It understands what's what. And so when you're done with the consult, you just hit stop on the app. You come back to your office and hit kind of Wi-Fi transfer, and it transfers the note for you.
Right.
So that'll save a lot of doctors time.
Okay.
From an oncology perspective, it can also kind of, if you think of Amazon, where you buy a book and then afterwards it says, well, if you like this book, you might want this book.
Right.
So it can do that in the medical record as well, that, hey, you ordered this CAT scan. Would you also like to get this lab with it too? So it can kind of pre-think you. So there are some things that are good about it. It's still definitely, you still have to QA it. You still have to edit it.
Certainly, yes.
And then, it's kind of your plus and minus. For me, my clinic doesn't have the volume of turnover that you would in like a primary care. So I'm not sure how much I'll use it in encounters. Like, I really like to engage with my patients, and I'm just not a fan of having an app on my phone, so for me personally, but other physicians, I know it'll be incredibly beneficial.
Yeah. Are there any specific types of cancer that we're getting pretty close to a cure? I don't know if a cure is the right word, but
I mean, there definitely are some that are pretty close, to a cure. So, for example, leukemia back in, the 50s and 60s was not a great outcome, and especially in the pediatric population. And, now it's like 80-90% cure rates, pediatric leukemia.
Amazing.
Breast cancer. So breast cancer often has 3 receptors on it. So breast cancer can be sensitive to estrogen, progesterone, and then what's called HER2. So estrogen and progesterone were the best ones to have because we could target them with additional medications. And then HER2 used to be considered an aggressive and, difficult one.
Yeah.
Now we have a ton of medications that target that HER2 receptor.
Yeah.
That HER2 is essentially equivalent to an estrogen receptor positive one. So those patients that had poor outcomes are now having much better outcomes. So we do have that transition now to higher cure rates, not 100%, but definitely higher cure rates.
Is it just, do you think you hit the right age for this? Like, you know what I mean? Like you're in the right era for the research and the technology and all these things, like gene therapy and everything else that's coming out. Like, is it kind of just like a fascinating time
to
be in the profession?
It's fascinating, but then it's also kind of a whirlwind because it happens so quickly.
Yeah.
And then you have to balance now too, funding is hard because a lot of these studies, you need to have so many people enrolled. The medications, if they're new, they're expensive because the research and development that went into them. And then you have to follow these patients for so long. So you're trying to enroll quickly, but then you have to follow them up. And so a lot of great opportunities because we have the technology, but still in oncology as well as any medical study, it still takes time. You have to do, 5-10 years of follow-up. Is this, is it impacting the survival rates, but also what's the toxicity?
Yeah. Gotcha. Yeah. Interesting. Yeah, like, I mean, Josh, before we started today, Josh, who's our audio engineer over here, but he was talking about his father's scenario with cancer and that kind of thing. And then my mother died of pancreatic cancer.
Oh, gosh. Yeah.
And my sister got screened for it. She doesn't have the
genes.
Yeah, the gene and that kind of thing. But, like, I guess what I'm trying to point to there is that we all know somebody that's, and I've got friends right now who are either going through treatments or recovering. It's, it's just one of those things like, it's either going to be us or somebody we know.
Oh,
right?
absolutely. Yeah.
So when someone in our community hears the word cancer for the first time, what do you want them to understand that they probably don't?
So, take a deep breath.
Okay.
We oftentimes have to complete the staging, so the stage dictates the treatment. Cancers that are caught earlier often have less treatment recommendations, which means less toxicity, and also caught earlier means better outcomes. So hopefully we caught it early. Yeah. And even if it's an intermediate or a slightly advanced stage, we still have great treatments. Like I was saying, all the immune therapy and targeted therapy now that people are living longer with good quality of life. So there's still really great outcomes. And then I tell patients, if it is a more aggressive cancer or poor outcomes, I always have that conversation with the patient. One, how much do you want to know? Because some people actually just don't want to know.
Yeah.
And that's their right. And then if they do want to know the answers, I tend to tell people because they're overwhelmed at the time, I'll be blunt with them. Yeah. I'm kind of a naturally blunt personality, but in that setting, I'll preface it by saying, I'm going to have a blunt conversation. It may kind of sound harsh, but I want to make sure we're on the same page because you need the correct information to make an informed decision.
Right.
But I do it for you out of respect and love. When you come into my clinic, you become part of my family, and so how would I want to be treated? How would I want my family members to be treated? Yeah. And so I would want to have a clear conversation to make the best decision for myself or my family member. So, so I do have those if patients want, for the harder cancers, if they do want to know the outcomes, we have that clear conversation and I give them all the information and, pros and cons of treatment, potential side effects. And then, I'm there for them. And I always tell patients, it's never my job to take away anybody's hope. But I also don't want to give false hope, because if you do have a short time left, do you want to be inside the gray walls of a hospital or do you want to be outside with the sun on your face with your grandkids or your kids or, so just making sure that we're on the same page and whatever the patient wants to do at the end of the day, I'm here to support you. So, so just having those conversations with patients.
Yeah. It's it all comes back to being pretty much human. And like we were talking about, like it's kind of hard to get people to buy into self-care and that kind of thing. And, but it's just awesome. I really appreciate that you having you come to our community and bring your skill set and help so many folks.
Oh, thanks. Yeah, no, everybody's been so welcoming. I've had a great time here. I always tell people that come through, hands down the crew at Celilo Cancer Center. So I'm the medical director of radiation oncology, but I'm also the interim director of medical oncology. Yeah. Just because we do have those kind of temporary contract physicians who have been long term. We've had 6-month and year-long physicians upstairs, but for me as the interim director for medical oncology, it helps provide that continuity for the staff as well as the contract physicians that come through. But working with both the medical oncology staff and the radiation oncology staff, I tell people hands down, it's the best crew I've ever worked with. And I've worked in, multiple states, both military, federal, and civilian. And so I always liken it to that the staff is not only clinically sound, they're good at their job, but they're psychologically sound. So they're good people that want to be there. And I've worked at jobs where those two things did not exist. They were either one or the other. Never did the two meet. And I do have to say, you do have a world-class staff at Celilo Cancer Center. It is one of the best teams I've ever worked with.
Fantastic.
Yeah.
What would you say would be like your top 5 cancer prevention tips?
Oh yeah, absolutely. No, I do a social media thing on that at the beginning of the year to remind people for the year. So number 1, don't smoke. Don't smoke. So that's cigarettes, that's tobacco products. There is not currently any data that supports cancer connection to marijuana smoking, but again, your body is meant to breathe in oxygen. So I would try to get you away from smoking marijuana or vaping. Those are irritants to your lungs, and putting your body in an irritant state puts you in a pro-cancer state. So
what about edibles?
Edibles are okay. Yeah. So that's not a cancer-causing issue. It's not irritating your body. But again, you're meant to breathe oxygen. So if you're going to put smoke of any type into your lung, it's an irritant. And that irritant's, again, pro-cancer.
Yeah.
Well-rounded diet. So Everything in moderation. So you can have, the piece of cake, just don't eat the whole cake. You can have, the steak, but it shouldn't be steak every night because red meat in excess can increase cancer risk too. Eating, if you can, the pasture-raised, grass-fed, it's healthier. It has healthier fats in it, less saturated fat. It's a better protein for you. And eating your fruits and veggies. So everything in moderation, well-rounded diet. 3, exercise, at least 30 minutes of daily activity. It doesn't have to be all at once. You can do 5 minutes here, 5 minutes there, but 30 minutes of daily activity. Alcohol in moderation. So there are guidelines in regard to alcohol and cancer risk. So for men can have 2 drinks of alcohol a day, and women can have 1 drink a day. And so you have to know the serving size. So a serving size is a standard can of beer. I know we have a lot of breweries around here that breweries do bigger cans. It's not the big
What about
can.
a 9% beat breaker?
I know. Yeah, so one can of beer, your standard, like a Bud Light at the grocery store, like
5%, 4 or 5% alcohol.
Yeah,
okay.
or 1 shot of hard liquor, or a glass of wine, which is 6 to 8 ounces. And a lot of restaurants actually do heavy pours, so it's probably half the pour of a standard restaurant.
Yeah.
So that's 1 serving of alcohol, 1 of those. Mm-hmm. And you can't hoard them. So you can't say, I didn't drink Monday to Friday, so I'm going to have 10 drinks on Saturday. That's not how it works. If you miss your day, you miss your day. Because, again, that's the threshold of what puts it into an irritative substance for your body. So 1 drink a day for women, 2 for men. But if you're going over like 5, 10 a day, that's an irritant, puts you at risk for a lot of cancers, head and neck cancer, stomach cancer, things like that. So that's number 4. And then number 5 is just knowing your family history and getting screened appropriately. So the screening guidelines for mammogram, getting your PSA for prostate cancer, colorectal cancer are based on an average risk patient. But if you have a strong family history, you need to know what cancers were your family members diagnosed with and what age, because that can put your screening earlier. So, for example, if you had a mom who was diagnosed at age 40 with breast cancer, her daughter actually needs to get a mammogram starting at age 30 instead of age 40.
So my mom had pancreatic cancer and got it at 63.
Yeah.
Do I need to go get a screening on that?
So there are unfortunately no current screenings for pancreatic cancer.
Okay.
So I'd just be aware of symptoms.
Yes.
So kind of vague abdominal pains or abdominal pain that, shoots to your back. Those are kind of more pancreatic systems, or jaundice, or, problems with digestion. But unfortunately, pancreatic cancer currently does not have any true screening guidelines for it. There are tumor markers. Once someone is diagnosed, we can follow their tumor markers, but we don't follow them preemptively up front.
Okay.
But so those are the 5 main things for cancer prevention that kind of apply to all cancers and to everybody.
Okay, so just cellular damage. Things that cause cellular damage.
Yeah, exactly. Yeah.
All right. Well, thank you for coming in today, Winnie. I much appreciate it, and I'll see you at the mailbox.
Yeah, absolutely. Thanks so much for your time. This has been a lot of fun.
It has. Thanks.
Thanks.